Good morning, everybody. My name is Carole Rosenberg. I am here with Terumo Cardiovascular. I am one of their clinical specialists. I am in the place of Verna Nelson, who was not able to attend, so I will be giving her presentation. Just a little background. I've been working with Terumo as a clinical specialist for the last 2 years. I am a clinical certified perfusionist. I maintain certification at University of Virginia. And I have just recently retired from the American board as a board of director for the last 12 years. So today I'm going to talk to you about, it actually says goal-directed perfusion monitoring. When we had started this presentation, we did not get our approval from the FDA at that time. So the presentation was talking all around what this big unveil is, but now that we do have our approval, we can actually talk to you without having you sign a non-disclosure form. So we are going to talk about the CDI OneView system that is now approved by the FDA and will be able to be sent to our customers very shortly. So with that, we'll get into the presentation. And thank you for having breakfast. I told my husband, I said, he hates having breakfast in the morning. And I said, I get to have breakfast with all of my friends. So, all right. So the CDI OneView monitoring system has a lot of the parameters that we are used to seeing. It is still an inline blood gas monitoring system, but we've added a very important feature to it that I'm super excited about having, and that is our extraction ratio number, so that you no longer have to manually calculate it. There's a lot going on in our cases. Our cases are getting more complex. They're very busy. And so to have to constantly being aware and that you want to calculate what that extraction ratio is becomes a task that is sometimes overlooked. And so now with the OneView system, it is an actual parameter that you can have continuously being monitored during your case, along with area under the curve. And then also we have flow probes that you can attach to the OneView system. So now, you know, when the surgeon is not very happy about venous drainage, you can say, well, sir, you know, 2 seconds ago I was flowing venous return was 5 liters, and now I'm only at 2 liters. So I'm thinking we need to look at the field and not back at me. So there is a lot of accents that we have attributed to the old CDI 550 that we have given that is actually going to even help us have the tools to be that much better for our patients, patient care, and also trying to fight the battle of winning AKI postoperatively. So like I said, you still have your DO2, your VO2, but the extraction ratio, the area under the curve, and the cerebral oximetry. So we can actually bring in other medical devices and see that on our actual screen. And as I showed you earlier, let me show you right here. Oh, where did it go? This is the actual, what it looks like. If you've gone to our booth, it is there. It's kind of small, which is actually really a good thing for us, right? Because there's not a whole lot of room on our pumps. But it is currently available at our pump, so you can actually go through it, look at it, see how it would apply to your program and how it would help you in your quest for excellent patient care and decreasing morbidity and mortality. So as you can see over on the side, you know, the arterial and the venous, it's not a very good picture. Like I said, we did this presentation before we knew that we were FDA approved, and we just got FDA approved, so we didn't have time to revamp it. But you have, you know, your arterial and your venous like you always had on your CDI 550, 500, but there's another section and it's called other, and you can really clearly see that if you go and you pass by the booth, and you can see, and that's where you'll have your O2 extraction. You can decide if you want to slave the flow in from your heart-lung machine, or do you actually want to utilize some of the flow probes that we have available for purchase, being arterial, venous, 1/4 inch, 3/8 inch. So moving forward. And so, as we know, we brought a lot of our information from the data that's out there. And as we know, data is extremely important to us. We hear it all the time. You know, they're like, well, I'm not going to do anything unless you show me the data. Well, over the years, the data has been shown to us as perfusionists and as medical device companies. And not only that, the community has also asked for specific helps with their patient care. And so back in 2000, Turbridge and Otten's papers were pretty significant in explaining to us the importance of inline blood gas parameter management. And so basically they were saying that, when you fell outside of the range, and what's good about the one view is that you can set tight ranges with alarms so that when you're busy with your case, that it'll either audibly alarm at you or it'll flash, letting you know that you are outside of the parameters that you set for your institution. And yesterday, when Tyler Kettling from Maine Medical talked about, his experience with his microcardioplegia, he talked about he didn't want to know what the numbers were for the world. He really wanted to know what that is for Maine Medical. And that is the truth of what we looked at doing, is that we want you to be able to set the ranges that are important to your program. And yes, guided by papers, research, and data, but everybody's ranges are different. I could go from one hospital to the next, and they might have different monitoring systems, different parameters. And so you can set them as you need them, but it actually showed like the complication rates increase. So when you fell out of range, your complications will increase. You're going to spend more time mechanically ventilated. You're going to spend more time in the ICU, and all that equals is more time and cost from the hospital. So basically, Otten's paper is a really great one, and he just talks about improving cardiopulmonary bypass. And this was done in 2010. So we're 2024, and we are still working hard to be able to answer the ask from these papers and from the community on how to better manage our patients. And so the value of his paper is that statistically difference between the percentage of cases where PCO2 deviated from protocol between the control group and the CDI system. So we're not even, in 2010, we're not even talking right now about DO2, VO2 extraction ratio. We're just talking about your CO2 being out of range and how it causes issues with autoregulation in brain and lungs and flow. So, and then we go on to talk about GDP, and we all know about GDP and the importance of GDP. I think that even when I was just in Singapore about a month ago, they all know about GDP. So it is a worldwide quest for all of us to give goal-directed therapy to our patients, specific to our institutions, specific to our patients. And so that we know that with the movement that we've had with GDP, that we have seen improvement in outcomes for our patients. But we still have a ways to go. So it is applied to our perfusion practice. I think all of us are doing some sort of GDP, if not all of the requirements for GDP. And it encompasses the ongoing effort to institute specific perfusion practices with the goal of improving outcomes. And so I was just talking to a colleague this morning, and we talked about that it's a lifelong process, that it's not just like, oh, I got it, I got this technology and I'm going to follow my DO2. It's deeper than just DO2. And so that's a continued learning process of, now we're looking at VO2 and we're looking at extraction ratio. We're looking at all of how everything is connected. So we can't just say, okay, I got it. I got one thing, because there's so much more for us to learn. So improving patient outcomes, as we just talked about, that we know that goal-directed perfusion, helps us with the outcomes and managing our patients. We also know that its immediate leads to discussion of DO2, like we just discussed, and its relationship to adverse outcomes such as AKI. But we also know that DO2 is not the only thing that contributes to AKI. We also know that we need to be looking deeper. We need to be looking at more than just the DO2. So the implementation of goal-directed perfusion has been associated with lower occurrence of postoperative AKI. And that is a huge thing, because as we know, that is a huge expense to our hospitals. That is a huge burden to our patients that have come to actually get better, and then they go home maybe not feeling as good as they did when they got to the hospital. So the potential reduction of blood transfusions, nobody wants anybody else's blood. So it is our responsibility to make sure that we as perfusionists can do everything we can to make sure that we do not give blood to our patients. Not to say that if the patient needs blood, they shouldn't get blood. And then shorter hospital length of stay. I mean, that's so important. how long you're in the hospital. It also has a lot to do with your mental health too. The longer you're in the hospital, you have that doom and gloom and the depression, and that doesn't help you get better either. So the quicker that we can get those patients back out of the hospital, back to the life that they had and living a better life, the better their outcome is going to be post 30 days. So some papers about DO2 as an independent risk factor for AKI after bypass. Ranucci, I mean, he's huge. I mean, as you can see, there's 4 papers that we're going to cite, and Dr. D. Sommer. So, Dr. Ranucci did a lot of research, a lot of data, telling us about the importance of DO2 and why we need to be looking at that. And so his best predictor is coming up with what your lowest DO2 critical value is, that if you fall below a certain range, you're going to, maybe potentially have some AKI postoperatively. But we're also now looking at, tagged onto what Dr. Ranucci did with his studies, that we're looking at, well, how long did you spend underneath that critical range? That's just as important, okay? Because we know that during our cases that the DO2, the VO2 extraction ratio, it changes constantly. And so that, you could be perfectly fine DO2, you're doing something with your case, maybe getting a blood gas, and you turn and you look, and the next thing you know, your DO2 is now dramatically decreased. So you have the opportunity to rectify that, to change it, or to try and troubleshoot as to why your DO2 dropped. And so with having that continuous monitoring of the DO2, the extraction and the VO2, you can actually see it in real time. So you'll know quickly, am I in aerobic state? Am I moving towards an anaerobic state? And with that, is my lactate going to increase? Well, you will see it quicker on your machine than you will, 30 minutes from obtaining a blood gas. So the lowest hematocrit was also an independent risk factor, 26. So he knows that only the lowest DO2 remained an independent risk factor when we looked at the predictive value of the cutoff of 26. And then the high degree of hemodilution, we're constantly looking at our circuits. We're constantly looking at how can we decrease the prime volume to these patients. Tyler, to cite him again yesterday, talked about, his patients that were hemoconcentrated had the highest risk of AKI. And, we do take off a huge amount of volume when we're giving del nido cardioplegia that we are now using for adults. And so, we don't do it. We do it because that's what we feel that we should be doing, or we're trying to lower the K. But, we also know that hemoconcentrating is not necessarily beneficial to the patient, that we would prefer for them to be able to remove their own. But, we're giving them huge amounts of del nido cardioplegia. So Ranucci in 2015, and this is 10 years from 2005, his journal carries weight in the world of cardiac surgery and practice of perfusion. So by 2015, we've really decided that Dr. Ranucci knows what he's talking about, that he really has something to say to us as perfusionists in the community. And so that transfusion itself is a contributor to AKI. So yes, we need to look at, what, our transfusion trigger is, but then we also need to look at, the rate that, it can also contribute to AKI. So what he tasked us with is looking at even decreasing your prime volume by 150 mLs is a huge significance in the quest to fight having postoperative AKI. So, when you look at cutting out extra tubing, you're like, is it worth it? 150 mLs. I mean, that's not a whole lot of prime. So it shows the evolution of goal-directed perfusion from simply adjusting pump flow to a whole series of interventions. And so he really tasked us, and he continues to challenge us to find the answers, to do what's best to take care of our patients. And so in 2018, he came along again and he had a study design, and it was the gift of 2018. And so he looked at 326 patients undergoing cardiac surgery, and he had the goal-directed group, and then he had the control group, 170. And so basically his results were significant, and stage 1 AKI was reduced in patients treated with goal-directed perfusion. So right there, 2018, we're saying that if we follow the goal-directed perfusion, if we have decrease hemodilution, look at our transfusion rates, that we're going to actually help these patients from the stage 1 AKI. And so stage 2 and 3 did not differ statistically between the two study groups, but there was no statistics difference in secondary outcomes. So basically, he said that RBC transfusions in the ICU was independently associated with AKI stage 1. I mean, a lot of us, we leave the OR and we're like, wow, we did a really great job. We didn't give any blood, but that as soon as they hit the unit, that they're most likely going to get blood because they have blood draws. We need to look at how often, are they drawing blood up in the unit? Is it necessary? Every time they draw blood, they're taking that blood from the patient, decreasing their total blood volume. So that is one of the things that we also need to look at as institutions, is not just what's going on in the hospital, but what's going on postoperatively in the units. Patients in the GDP arm were less likely to be transfused after bypass, but more likely to be transfused during cardiopulmonary bypass. I've always thought to myself, is it better, because we know that we're going to have to give this patient blood, is it better to give that blood in the operating room on bypass than sending them to the unit to give them a unit of blood? Does it make a difference? The data suggested that transfusing RBCs during a critical period of bypass may result in less AKI. So that was in 2018. He's saying, you know what, if you need that blood, if you truly need that blood, give that blood. Don't just be like, hey, you know what, I did that entire case, I didn't give blood, knowing full well that they were going to go to the unit and most likely have blood, or come off pump and anesthesia is just going to hang a unit of cells, because that's truly what the patient needed. So this may be due to renal cell increased sensitivity to hypoxemia during bypass. And so the 5 laws of GDP is limit hemodilution during goal-directed perfusion. I know that we've heard it and we're going to continue to hear it, because we do know from all the research and the data that it is a huge predictor of potential AKI. So you want to maintain your DO2 over 272. That is the number that he came up with all of his research and his studies. And that you want to increase your DO2 by acting on pump flow and PaO2. Well, now with the CDI-1 view, we have the ability of using a venous flow probe, which is so important. I personally am hoping that we will be able to get a venous flow probe at our institution, because how many times are you trying to explain that, it's nothing back here. The surgeon always thinks it's the perfusionist's fault. The perfusionist always thinks that it's the surgeon's fault. But now we'll actually have proof. You're like, okay, well, I can look back, I can pull up my graph. So the one of you does a really beautiful job of being able to graph and see over course of time. Okay, my flow was here, but then you move the heart up in the air to be able to see. And we understand that you do need to see what you're sewing to. But now my flow is decreased. My venous return is decreased, which decreases your flow. So you can actually have proof, and that they can't refute. You're like, well, the flow is here and now it's here. Before you would look at it and be like, well, I have decreased flow. They're like, well, what does that mean? Well, I had 600 in my reservoir and now I only have 200. But they can actually now, they understand flow. My return is only 4 liters. It was 6 liters. So transfuse RBCs based on SVO2 and oxygen extraction rather than just hematocrit alone. So I think that that's important, because how many of you guys are looking at O2 extraction in your practice? Yeah. So not many of us. So we as perfusionists have a lot of learning that we still can continue to do. And so O2 extraction, I myself am a learner of this. If you have the chance to talk to George Justison over there, he has a wealth of knowledge and has taught me so much about it and the importance of it. I mean, we were taught about it in school, but I've been doing this 27 years. And when I came out, we really, as long as your SATs were above 70, life was good. But we now know that life isn't necessarily good. Maybe good for you, but maybe not necessarily good to the patient. And so by challenging people to understand and learn about the O2 extraction, you'll see how quickly you can go from the aerobic to the anaerobic stage, and how quickly that's a predictor of whether or not your lactate is climbing or decreasing. So O2 extraction, I can't stress how important that is. And I myself, just until recently, wasn't a true understanding of what that meant in terms of bypass surgery. So the great thing is that Terumo has included that in the CDI-1 view. So now you can continuously monitor your O2 extraction, and you can jump on that quicker than you would every 30 minutes if that's what your blood gas draws are. So in 2015, Ranucci just goes on that his conclusion is that low crit values during bypass may trigger inadequate level of oxygen delivery, which are associated with an increased risk of postoperative AKI. So this pattern may be corrected by adequately increasing the pump flow in the presence of low hematocrit. And so with the advances of technology and being able to use a device such as the CDI OneView, you can actually see that if I increase my flow, even though that my crit is lower, but if I increase that cardiac output to that patient, that you may not have to transfuse that patient. So is it the crit that's causing the issue, or is it my flow? And then by also being able to use a venous flow probe, you can actually see, well, if you can position the cannulas maybe a little bit better, or we can try and move them around, I may be able to get better return, better visualization to you, and then a better outcome for that patient. So here's a nomogram, which I think is really important for those of you who do not have the ability of, looking at a CDI or a device that'll give you your DO2. You can see that your hemoglobin up at the top is a certain level, and you can see your blood flow. And then you can see that if I increase my flow, but not necessarily my hemoglobin, you can see what your DO2 would be and as to whether or not you would be in the range. But what I challenge you to is that, okay, you looked at your DO2, but now what does your VO2 look like, right? What does your extraction ratio look like? So just because you bring that horse to the water doesn't mean he's going to drink it. Just because you're delivering a high oxygen content, right? That DO2, it's telling me my oxygenator is working. My oxygenator better be working. I paid a lot of money for it, right? But is that patient accepting that oxygen that you're giving them? And are they extracting too much because they are in a state, maybe, a lot of our anesthesiologists believe in fast tracking, and I think it's a fabulous thing that they're doing for patients. They don't want them, snowed under like they used to. It was a lot easier to do cardiac surgery even 15 years ago, where sedation was fabulous, and patients, their metabolic rate was so low, but that's not the case anymore. A lot of them fast track. And so we need to give them more flow. And so by doing that, we need to look at, like, are they extracting more than they normally would? And can I answer that? Can I pick up my flow? And so goal-directed perfusion goes on to talk with Long and Kramer and DeJoy, who Dr. Kramer, I love his paper. He, in my mind, talks about basically what we need to do, not just intraoperatively, but postoperatively and preoperatively. Just recently, University of Virginia has looking at these patients before they come to surgery. Are they anemic? Do they have creatinine issues? Because we really want to know, did we cause the issue? Did we exacerbate the issue, or did they already come to us with AKI, but the patient didn't know? So, I mean, they have severe heart disease. If they're coming for cardiac surgery, that means that their cardiac output probably is not very good. Their heart's not working. So that's going to affect so many other organs, and one of them being the kidneys. So we really, as institutions, we really want to know, did that cause because of us, or did they come to the hospital for surgery with that already? Because we want to be, and the reason, by being able to know that, it helps us to be able to tailor their care, to tailor their course of care throughout the hospital stay. So, like I said, Dr. Kramer looked at everything about oxygen outlet temperature should never exceed 37 degrees. I think most of us perfusionists have adopted that. Takes a little bit longer to warm our patients, but I think that we understand the significance of increasing that outlet temperature. And that a 34% increase in AKI for every 10 minutes above 37 degrees. I'm like, wow, that's a significant number. So area under the curve, so the OneView, which is really exciting, actually can measure the area under the curve. So they're saying, like we talked about a little earlier, is that throughout the case, your numbers are going to, they're going to go up and down throughout the case, but how long did you stay under, right? So the great thing is that the OneView has this actual ability to snap a picture of what the graphs look like. So you can say, all right, look, doctor, you didn't want to fix my venous flow probe. Of course, we wouldn't talk like that. But, but I'm going to tell you right now, look how long I was under the curve until you decided that, yes, this was a priority and I should have really fixed that positioning of the cannula. So area under the curve, we're going to hear more in the coming years and the more talks that we have, because that is like, as we said, your case is going to continually roll. It's not common to have a case that's just like this, right? At least not at my hospital. This patients, as we know, everybody says they have the sickest patients, but I feel like we do. But it's how long did you stay down until you were able to fix it to come back up? And so this is what we talked about here. And so this is, so oxygen extraction. So this is a better picture of the CDI1 view. And as you can see, we have the ability for the arterial. You can actually put in a venous sampling as well for inline blood gas monitoring. So those of us who are doing cases that look at VV, you can actually use a venous inline blood gas monitoring to see how well your patient is doing. But at the same time, you can also look at your DO2I, your index. You can look at your VO2I, and then also your extraction ratio. And then at the same time, you can bring in, you can see, it's kind of hard, but hopefully you can, that you can actually add a flow probe, and you're going to say, okay, I'm going to use arterial, and where it's red, that denotes arterial. And then you can also see that you're bringing over the flow from your heart-lung machine. So you can see the difference between, pre-shunt, post-shunt, and then you can look at your extraction ratio. And then the great thing is if you touch the actual, like where O2 extraction is, it's going to bring up the graph, and then you can see what that is over the course of your case. Also, there's another area down at the very, very bottom. You can see it's like red and yellow and blue. That's actually the graph. And when you hit that, you can actually preset like 4 different parameters that you want to look at in a graph. And so they'll either overlay them or they'll go stack them. So you can see that throughout the course. The other great thing is that this actually connects with the data management system. So if you are using electronic charting, you can send it over, no issue. The other great thing is those of us who are not using electronic charting or not using automated electronic charting, you actually can save the actual case and then print it out and make that part of your record, or just keep that information for research and data in your own pump room. So I feel like this is a really great tool, especially for those who do research, and also for the patient, because it helps us to support what we're trying to say in the OR. So if we try to, if we go to M&M and we're talking to the surgeon and we're trying to say, well, you know what, I really couldn't flow because of this, but now you actually have data to support that. You can say, look, you know what, these were my flows. This is what I did. These were the interventions that I did. And it's proof, and you can't refute it because you can't go in and audit this. So what it is what it is. So it's really hard for the surgeon to come up with an excuse to say, why didn't you look at the venous cannula when I told you there was something wrong? So supply versus demand, we know the equation. It's very important. Hemoglobin, blood flow, right? And then you've got content. So Condello actually has done a really great job in his paper that just came out. It's not 2023. Sorry about the typo. But his conclusion is that the analysis demonstrates that the management of indexed oxygen delivery in relation to oxygen extraction was 16% more specific in terms of negative predictive value for hyperlactemia during bypass compared with the use of cardiac index in relation to the SpO2. And so, like I said, when I got out of school, that's how, as long as your SpO2 was greater than 70, your life was great. But that's not the case anymore. And so it's not okay just to flow by sats, by the color of your blood. We really want to know, okay, I'm delivering really great oxygen, but how much is that patient extracting? How much is that patient actually using the oxygen that I'm delivering? So just to think like, okay, well, my DO2 is over the critical threshold, but we need to go deeper than that. We need to understand, what is that patient using, and how much is that patient using? Too much because maybe he needs a little bit more sedation, maybe he needs some more flow, or maybe truly my hematocrit is really too low for that patient. So these are really great ways that we can help our patient to do better and have better outcomes. So the group managed with DO2 and extraction ratio reported a significant reduction in the incidence of intraoperative lactate peak, correlated with postoperative reduction of serum creatinine value. I have this really great pediatric surgeon that I work with. I love him to death. And so probably about 6-7 years ago, I used to, we have the fortunate of having a blood gas analyzer in the OR right at our pump for the peds cases. And so I would always get a lactate because to me it was important. It was telling me, what am I doing to that patient, right? But the lactate, that I get, it's only every 20 minutes, every 30 minutes when I do a blood gas, because I do rely on my CDI 550 as it's a very accurate inline blood gas management system. And so he's like, why you always got to tell me the lactate? I don't care about the lactate. He's like, but as soon as we hit that unit, that's all he talks about is the lactate. I'm like, but why now all of a sudden is it important? But you didn't really seem to care about it when we were in the OR. But as soon as we hit the doors of the PICU, it's like, what's lactate? What's the lactate? I'm like, oh my gosh. Like I was trying to tell you during the case that, but he's really great. He's very responsive, but it always made me laugh that, it's just the educating our surgeons, educating our team, making them understand the importance of all this. And, he knows that I'm just going to tell him the lactate no matter if he wants to or not. But knowing what the lactate is more onus on me to make sure that I can do what I need to do for that patient. And so AMSEC has done an amazing job with their standards and guidelines, and it helps us to support our patients by giving us leverage with administration to say, look, this is standards. These are guidelines. This is our national society. These are them saying that you need, shall be maintained, not just should be, could be, but shall. Shall is a pretty strong word. So, and that speaks to lawyers, that speaks to patients. I've worked with lawyers that have pulled up our standards and guidelines and are like, well, here it is right here. What are you going to say about it? This is how your community needs to or shall practice. That's a strong word. So kudos to AMSEC for really nailing this down for us. It's extremely important. Pediatric AKI, Hayward came out with a number and he said to us basically, you know what you do for adults, as we all know, is not good enough for peds. So we know that they have a higher metabolism rate. They're going to need higher DO2 extraction VO2. So just basically goes on to talk about AKI in pediatrics and just basically how he determined that his critical number is 350. You can pull up several different papers. They're all going to maybe potentially give you a slightly different number, but the onus on all of them is the fact that pediatric patients need a higher oxygen delivery than adults. And so pediatric AKI just basically supports previous findings that DO2I during bypass is an independent risk factor in AKI development in pediatric patients. I'm very fortunate at where I do my cases is that, our surgeons understand the importance of flowing high. And so we're able to maintain a cardiac index of 3 throughout our cases. And because of that, we have almost zero AKI incidents with our pediatric patients, has to do with flow. So the fact that we're going to be able to bring in an extraction ratio and the VO2 continuously is pretty exciting to me. And then also being able to look at the venous flow back to me, because the surgeon will be like, okay, I'm getting ready to open the heart, I want to tie down the cannulas, is there any change in your return? And I'm looking. It's really hard with pediatrics, and you're looking, because as soon as you say no, we're fine, then you turn, and the next thing you know, you've got venous decrease. So now I can actually see it with a venous flow probe versus me staring at it. So I'm pretty excited about that. So the financial impact, we all know it is so expensive. These are the numbers: $1 billion. Money talks. So when you look at your administration and you're trying to, they're asking you, do you have the tools to be successful? Do you have the tools available to you to take care of patients? It's on you to tell your administrators, your surgeons, I really need help. These tools would help me to improve patient care, patient outcome, because it's not just a one hospital problem. It's a problem throughout the world. AKI, we talked about it in Singapore. We talked about it in Thailand. We talk about it in the United States, but $1 billion is a lot of money that we could use somewhere else. And so these are our references. And then I have my QR code if you like. And then I have a quote, and I just basically said that, we cannot underestimate the crucial role perfusionists play in optimizing patient outcomes, especially in managing comorbidities like acute kidney injury. Staying updated with the latest research, implementing best practices and technology combined with effective communication are essential for providing high quality, personalized care to patients. So that is my pitch to you guys to go out and, evaluate your program, look at your program, figure out what tools do you need to even make things better for your patients. So I appreciate your time this morning, and I ask you guys to stop by the booth to really look at the OneView and to give us feedback, because that's how we improve, that's how we change. We learn from the community. Did this help your practice? What could we do better? Thank you. Any questions? Yes. There you go. It was an easy one. It's a lot for the morning. All right. Thank you, guys. Like I said, come by the booth. It's there on display, and you can see, how it works, how it functions, how it's set up. And like I said, it's really great is that where I work at University of Virginia, we have several pumps, and each pump has a different specific that it uses different cases that it's good for. Like we have pediatric pumps, we have adult pumps, we have pumps that we use in TAVRs, mini mitrals that we have. And so you're able to customize the OneView to that pump that you might need. So maybe you don't need a venous flow probe, or maybe you need more than one venous flow probe. Maybe you need, you want to be able to pull the flow from the heart-lung machine. So that to me was really exciting, is that we're able to customize it, not just to your program, but to the pump that you're using. So
I'll ask a question while it gets to, working out. I have to say I've failed with this agenda, because actually I didn't realize you were going to talk about this. Otherwise, I put my talk next, because I'm about to do all the oxygen extraction ratio data.
Oh, good.
So it'd be interesting to see that you're going in that direction anyway. So it'd be great afterwards to have a conversation about how that data is used and what tools you use in order to analyze it. Obviously, displaying a number is one thing, but then interpreting it and how it changes is kind of a very different matter.
Mm-hmm. Yeah, I think the more that we talk about it, the more we're going to understand it. And I think it's going to be the harder for us as perfusionists to ignore. So, I mean, there is a fear about changing your practice and learning something new. I mean, because a lot of us, I've been doing it 27 years. So to be able to embrace something different than that I've done before. But then when you finally do embrace it, you realize, gosh, could I've done better in cases that I thought I did really well on?
Absolutely. And I think this harks back to the conversation and the discussion panel we had yesterday evening with Rob and Jim about the fact that this would give us more data to understand, what data we actually need, what's the value of this. Because I think one of the participants pointed out that you can have every number under the sun, but unless you know which one is important and why it's important, how it's important, and how it integrates with everything else, then it becomes just another number to look at, and it distracts you from what you're trying to do. So it's bringing those numbers that are important to the forefront.
Right. And I mean, we as perfusionists, these devices, no matter whose device it is, medical device, whether it's Terumo, LivaNova, Spectrum, they're not telling you what the problem is. They're just giving you the values. And you as the perfusionist are tasked with trying to investigate as to what it is. And so I know at one point, in my career, the cerebral oximetry, it was low. It was like at 15. And I'm like, what is going on? I was just floating in rooms helping. And I'm like, what, is anybody even looking at this? And anesthesia's like, oh, whatever. And then, but to find out when you investigate that it's not even on the patient's head. Right. So, I mean, that helps us, because we're trying to figure out, are we giving enough flow in that the head is receiving enough oxygen? So, it's on us to investigate. They're just giving us the information. We need to figure out what the problem is.
I think understanding, like say, what it is you're doing and what are the limitations of it as well. And you mentioned NIRS. We did an experiment a few years back, which was basically we brought in a cardiac surgeon and we brought in a pumpkin. And we put the NIRS on the surgeon, and we put the NIRS on the pumpkin, and the pumpkin had more cerebral flow than the surgeon. So, you got to understand what numbers you're actually getting. It wasn't Martin. I will just point that out just in case he gets upset. It was not Martin. It was one of our others. But, so these things have a way of giving you false data if you're not careful. So you do need to understand those limitations in context as well.
Right. They're only going to work as good as we investigate and understand their limitations, for sure.
Any other questions? Oh, go on. You want to? Come on.
It's a lot in the morning.
They're digesting breakfast.
I think it would just be really great to have the venous flow probe, because then you've got direct information
I
to
want one so
open
bad.
a discussion with your surgeon about cannula choice. Often our input is not taken into account, and it's just a struggle the entire case.
Right. Right. And so the feature, if you stop by the booth, you can see, which I think is really exciting, is, and I'm not sure which one of our engineers came up with it, is that you can actually hit snapshot of a picture of that. So you can go back after the case and truly show, or even during the case, you know, what your flow had done. Like all of a sudden you were doing great. Now you had to lift the heart up. And yes, I understand that, you know, you needed to see, you know, to be able to show that anastomosis, but look what my flow, my venous return did. Now look at my numbers, the area that I spent underneath the curve until you realize that I had an issue, right? So
cases you could say, well, when you use the 24, this always happens, but when you use the 28, it's a 30% reduction.
yes. Yes. Yeah. So, I mean, it's hard for them to refute the data because they're all about the data. So here's data. You know, they totally blow us off when we're like, venous return is bad. I think they think that we're not watching or looking. I don't know. But when you actually have numbers, all of a sudden now it's a whole different ball game. Yeah. So that's what Terumo aimed to do, to be able to give perfusionists the tools to be able to help take care of their patients.
Thank you.
Thank you.